You're listening to All Things ADHD, produced by CHAD, Children and Adults with Attention Deficit Hyperactivity Disorder. Learn more at chad.org. This episode is sponsored by Otsuka. At Otsuka, we believe every mind is infinitely valuable, including those navigating ADHD. That's why we're working to transform how neurodevelopmental conditions are understood and treated. Discover more at otsukaus.com/CNS. Welcome to All Things ADHD. I'm your host, Susan Booning, and I am CHAD's Director of Communications and Media Relations and the editor of Attention Magazine. My guest today is Dr. Dara Abraham, a board-certified psychiatrist who focuses on adult ADHD and mental health advocacy. She is in private practice in Philadelphia, Pennsylvania. Her expertise and insights have been showcased in articles, podcasts, and conferences where she works tirelessly to promote awareness and deepen understanding of ADHD and related conditions. Today, we'll be talking about women, hormones, and ADHD, more specifically about hormonal waves and ADHD. Dr. Abraham, welcome, and thank you so much for being with us today. Let's jump right in with this question. Why is it so important for a woman who has ADHD, and of course, mothers of daughters who have ADHD, to learn about and understand this topic?
Well, yes. Well, thank you for having me. I'm so excited to be here. And that, yes, I'm excited to just answer all these great questions. So to start there, let me say that this is really just such an important topic. So because hormones change everything for women and girls, ADHD isn't static. And really, the hormones play such an important role because it just ebbs and flows with hormonal shifts. Estrogen and progesterone really affect the brain and chemicals. And when I say chemicals, what happens is these chemicals are basically in the brain I'll break it down into dopamine, serotonin, and norepinephrine. And so the chemicals that we think of as that happen hormonally are estrogen and progesterone. So estrogen and progesterone in females, males have them too, but we're going to talk about females who that's the predominant sex hormones, can interact with the chemicals in the brain, such as dopamine, norepinephrine, and serotonin throughout the month. And so they can also regulate focus and mood and energy. And so when these hormones, such as estrogen and progesterone, fluctuate, our ADHD symptoms, women who have ADHD, can look completely different. So sometimes in the month, their ADHD symptoms are well managed, and other times in the month, they're not so, well managed. And so women, can feel like they're basically crazy when they say, hey, my meds are working now, and then other times of the month, they're not working so well. So that's really the gist of it. And it's very inconsistent.
Take us through what happens during each stage of a woman's life, the hormonal waves and fluctuations from puberty and adolescence all the way through what happens after menopause.
So basically, for many girls, ADHD symptoms really become first noticeable at puberty. It's not that that's when ADHD starts. It doesn't start at puberty. It's a neurodevelopmental disorder. So you're born with ADHD. It's not psychopathology where you acquire it or where it's, something that's more of like a depression or bipolar, that it's pathology and you notice it more in your late 20s. It's actually developmental. And so you're born with it. And what happens is, unlike I'm going to stereotype right now, but unlike little boys who you notice the symptoms a little bit earlier, for girls, you don't really notice the symptoms until puberty. And that's really because the ADHD, it's not that it's new, but because the hormones, basically the estrogen really and progesterone, they fluctuate. And at first, really what you're noticing is that the girls are usually just inattentive, that daydreamer, right? And then sometimes they're just a little chatty, but then puberty hits. And what you really notice is that they become much more emotional, much more dysregulated. Unfortunately, this is also one of the reasons why girls are really missed in diagnosis historically, because at this point, this is when they should be diagnosed. But what happens is they're missed because this is attributed all to puberty. This is hormonal. Oh my God, my teenager is so hormonal. They're going through puberty. But no, this is also twofold. A lot of, girls who also have ADHD, yes, they're going through puberty, but also this is magnified. This is ADHD on steroids. And so this is a time when we really need to take a look at it and say, hey, is this just puberty or something else going on too? And so basically, this is also, so that's one thing. And then during the menstrual cycle. So right before the menstrual cycle, what happens is every month, so this fun thing with puberty, unfortunately, just doesn't happen once. Then as females, this gets to happen every month. We get to have this little menstrual cycle every month. So estrogen is our friend. Females, estrogen's our friend. It basically helps dopamine stay elevated. And so that's great because it gives us alertness. However, during the month, which is basically if you have a normal cycle, just say 28 days, during the first part of the month, we'll say day 1 is the first day of your period. It goes up, up, up. So we'll say the first couple of days you're getting your estrogen's getting a little bit higher. So maybe you're not feeling that alert. Your meds are working okay, but not perfectly. Your stimulants like Adderall, Ritalin, it goes up. The estrogen's getting higher. You're feeling great. Your meds are working. And then all of a sudden, as the weeks go on, you're getting closer to ovulation. Things are not going so well. And you're starting to notice your meds aren't that great. And so the dopamine, really what it does at that point, it's really helpful, but it's slowly lowering. And this is also when your serotonin is kind of getting lower. It's dipping. And so at this point, both of those are no longer as helpful. And so your focus is dropping, your motivation is dropping, and so is your mood. And you're not as regulated. And so this happens right before your period. And we call this the luteal phase. And so basically, this is ADHD on steroid. This is when you get PMS. And so this is the menstrual cycle and what we call PMS. And when you have PMS on steroids, this is called PMDD. And we can probably get into this a little more detail, but this is premenstrual dysphoric disorder when PMS becomes more of a disorder. And that's more, when you have PMS that's actually affecting your functioning. And so then there's, hormonal shifts during pregnancy and then after pregnancy. And then that can affect you. And then there's hormonal shifts also right before menopause, which we call perimenopause, then menopause, and then also later in life. And that all is affected AD. So I'll go backwards. This all affects ADHD. And so what happens is during puberty, your ADHD is really affected by this estrogen and dopamine. And basically, anytime your dopamine is shifting, you're basically going to have less effective ADHD meds when the dopamine is low. And so up and down it goes. And so a lot of times I would say it's only in the past 5 years or so where doctors and still were really going to take that into consideration when patients were saying, hey, I don't think my medications are working. And it used to be just dismissed. But now I think it's more likely where at least psychiatrists are willing to accept the fact that is true, where patients do need boosters, meaning they may need an extra dose during that luteal phase, that 10 days before their period, or at least 7 days, or symptomatic relief, maybe just a couple, doses during maybe that 2 days when they're noticing the symptoms, or just more, maybe not more doses, but just a higher dose. Maybe the potency isn't as effective. And then also during the perimenopause, I always call it a second puberty, because what happens is people think, and this is really something that I really want to make clear, people think that during perimenopause, that all that happens is your estrogen goes down. And that's not true. What's happening is you're having this fluctuation of hormones. And that's why just getting your hormones checked during perimenopause to see if you're in menopause isn't going to help. And really, people think that, going to your OB and saying, I want my hormones checked is going to tell you if you're in menopause. That's not the case. Because if you get your hormones checked and you find out that that your estrogen is low, that doesn't tell us much, because the next day, the next week, your estrogen can be high again. And so that doesn't give us that much information. That's why perimenopause is really a clinical diagnosis. And anyone who tells you otherwise isn't giving you the full truth. Those companies now that, want to diagnose menopause, perimenopause online, I would be a little skeptical of that as well. But that's, a whole nother story. But I say that because that's another time where you really want to be mindful that your medications need another adjustment. And so that period in life, and you don't always know when that period in life is coming. And that's, something to be aware of. But so, that could happen anywhere. Perimenopause can happen in your early 30s. It can happen in your 40s. It can happen in your mid 40s. It can happen in your late 40s. And so at that point, your medications, your stimulants, usually we're talking about stimulants, but we could be talking about some non-stimulants. But usually when I say that these medications, I mean stimulants, may not be as effective because you're having such quick fluctuations of estrogen and progesterone. And your cycles are you're not regular. So those 28-day cycles could turn into 22, 14, and you're having ups and downs. Your estrogen's really high or really low. You're in a complete progesterone week. And so, so basically you're maybe even completely different than it was during puberty. And so then you get into menopause. And, menopause is one day. People don't realize that either. One day. You have menopause for one day. So that one day is, perimenopause is before all those symptoms, before, all of the hot flashes, the feeling, a lot of emotions, dysregulation, a lot of the times when your medications for ADHD are not working, when you're dysregulated, moody, depressed, physical symptoms. And then postmenopause is basically, we consider that, a year after you don't menstruate. And then all of the, that time post your childbearing years. And we have a much longer time than we used to. I mean, we're living much past back in the day when women didn't live as long as they do now. But that one day where you go from, having a menstrual cycle to not having one, that's one day. And so, but basically that there's a big change. And so women, remember, estrogen is our ally, is our friend. So when we don't have that anymore, there's a big drop. And so it doesn't happen, it happens it happens slowly. And so the first thing to really drop out of the sex hormones is progesterone. And that usually happens during perimenopause. And then, estrogen, but it kind of the way a lot of things happen in life. It's more gradual and there's back and forth and testosterone we also lose. And that's kind of the fun things like, you notice hair and growing in weird spots. You notice low libido. You also notice some other fun things. But the estrogen also, as you're losing, lowering in estrogen, and basically the dopamine is getting lowered, you start to notice a lot of that alertness, the forgetfulness, concentration issues. And so basically your ADHD meds can become less effective. So for someone who already has ADHD, this can feel like ADHD on steroids. As you can tell, someone who doesn't have ADHD, they can start having memory issues, cognitive issues. They can start thinking they may have some, new onset dementia, cognitive impairment. For someone who has ADHD, but it's been so mild, or they've had the ability to compensate their whole life because they've had a job that allowed them to compensate, or they've had a spouse who was their executive function, and then maybe their spouse just unfortunately recently passed, or they had such high anxiety or such perfectionism, whatever it was that allowed them to compensate, or their compensatory strategies are just so burnt out from all those years. That can be real nerve-wracking that they didn't realize they had that, and all of a sudden, their estrogen is so low, that their dopamine is so low that they're no longer able to maintain those strategies, that all of a sudden they feel like, what's going on? And really all it is it's really just that ADHD finally showing its true self. And so when I tell them that, they're relieved, but they can't believe it. So there's just so many presentations. So that's really how this hormonal wave and shifts really present throughout a woman's lifetime.
Throughout the lifespan. Thank you. That is such a great overview. Thank you so much. But let's back up to puberty and adolescence for a minute. And also young adulthood, when hormones are still coming into balance.
Yeah.
What can parents or young women do to make those early years with ADHD a little easier? And since the brain is still developing during adolescence, does that affect how girls experience period-related pain or sensitivity, how those cycles, and are there ways to help them manage that more effectively?
So I think that number one, I think that parents can really realize that this is out of their daughter's control, that a lot of this is biology. And so it really accepting that this is not within their control. And so really realizing that this is part of their biology. This is not voluntary. There's a difference between behavior and biology. So that's number one. I think acceptance, and I think helping them become aware and helping them really track. So we want objective data. So I think that when they start to see that this is cyclical and they start working within those bounds, they can really both they can both feel, them and their child can feel less frustrated. I think, data, information is power. And so when you don't have that, you don't feel as scared. And I think also that helps limit the shame cycle that really is such a foundation. I think females really, this is where it all starts, is that there's such shame and, not knowing what's wrong with you and why you're so emotionally dysregulated.
So it's really important during those years for parents and for young women to understand, to get that support and to understand this is normal, that this is, part of your biology. And I heard someone say something at one point that you've got to learn to ride the waves of your hormones or they'll take you for a ride.
Yes, exactly. And so, and you also mentioned about the pain receptor. So there actually has been some, studies and proof that this also can affect your pain receptors, and also that during the premenstrual time, these young girls can notice that their pain receptors, that they actually can have a lower tolerance to pain. And so this is the time that they really want to make sure that they're in preventative mode. And so really focusing on, making sure that they take their Motrin before the cramps happen, that they get heating pads before everything, is about to happen, that they really plan out what's going to happen, because it's just so interesting that it's almost like Groundhog Day. Like they just forget every month, especially when you have ADHD. And usually when the daughter has ADHD, one of the parents have it too. And so, it's really important to be mindful of the fact that this is going to happen monthly. It's cyclical. Really being mindful that their pain threshold is lowered and they want to really prepare. And also just being so careful not to shame, not to place extra guilt and embarrassment on them, since this is the formative years. And really, I think working with them, helping them really use one of those apps to really keep track. This is the time to help really build executive function.
So let's look at some of the treatment options overall. If you could talk about ADHD medications, exercise, other maybe some complementary and alternative treatments that are evidence-based or evidence-informed.
Sure.
And strategies that may be helpful during times of fluctuations.
Yeah. So basically, the number one, the most effective treatment for all stages of ADHD are stimulants. I would say the youngest folks who are, younger than 5 or 4, of course, you're going to still start with behavior modifications. You're going to be really working with parents. But as you're getting older, to adolescents, to children, really we're starting with stimulants. So with these folks, I really treat adolescents and adults. We're really starting with stimulants. They're probably one of the most effective psychiatric medications that I prescribe. Really, if we're looking at effect size, which is really what studies look at, it's so satisfying to see patients start these medications and how effective they are and how quickly they start working. So there's 2 different classes of stimulants. All the medications that are out there really fall under 2 classes, which is the methylphenidate and then amphetamine. So the methylphenidate is Ritalin, Concerta, Focalin, many others. And then the amphetamines are Adderall, Vyvanse, Dexedrine, and others. And so all of those are it's two different types of molecules that are working on chemicals in the brain called dopamine and norepinephrine. And these chemicals basically help to increase concentration, focus, alertness, motivation, and all the things that we need to get things done and organize and plan and sustain attention and stay alert and not be impulsive and not be hyperactive. And so that's number one. And so most likely, I would be starting with these medications. There are times when someone can't tolerate a medication like a stimulant, or it doesn't work well enough and I need to use something else. Maybe a patient chooses to they want to start something else. It's pretty rare that there will be a contraindication. For me personally, it's rare that there's any medical comorbidity. It's rare I won't start it because of maybe some history of drug addiction. It's pretty rare that I won't use it for any reason. But the next class would be medications such as antidepressant. The newer one is, there is something called Strattera that I don't really use that often. There are people who find it helpful. It definitely has some side effects. It came out years ago. It is an antidepressant that is used for ADHD. There are people who find it effective. I would say, if anything, it's used more in combination with stimulants. Then there's a newish one that's called Quellbrite, and it's basically a medication that's also it's basically it works on the norepinephrine. When I say antidepressant, they work on the norepinephrine receptors and serotonergic receptors, as opposed to dopaminergic receptors, dopamine. And so they just work differently. They're not basically working on dopamine. And so they're working indirectly to increase attention, alertness, focus. And then there's these other medications that or for adults are prescribed, it's not that they're not evidence-based. They're not evidence-based in the sense where they're FDA approved, but they're still evidence-based where we prescribe them off-label, and it's pretty common. And that's alpha agonists such as guanfacine, Intuitive, things like that. And they just work a little bit differently. But we really are primarily using them more for the impulsivity and the hyperactivity. Adults still commonly have those issues. It's just that they're not presenting to me as often with them. Usually kids are really struggling with them. They usually do present with them, but it's more of the internal hyperactivity, impulsivity, which usually at that point is sometimes presents more as anxiety or more internal hyperactivity where they really can't shut down at night. And so it usually is kind of commingled with anxiety or maybe some other secondary, impulsivity, such as, binge eating and things like that. With that said, I think, those are the main medications. And then, the old saying is pills don't build skills. And so really, along with medications, we really have to focus on skills. And so the skills really are basically the main thing is how am I going to, once I can focus, once I can motivate, once I can not be as impulsive, not be as hyperactive, how am I going to organize? How am I going to regulate my time? How am I going to break down these tasks? How am I going to basically get from A to B and then figure out how to still have time for this? All of these things, how am I going to do all of this in terms of getting everything done and still have time to enjoy my day? And so that really is something that really is working with the coach, having maybe an accountability partner, all of these things. And so I'm really always helping people explain that they really need to do more than just taking medication. And it's really ironic since a lot of folks with ADHD really just want that quick fix. Sometimes it works. Sometimes that's all they need. It really just depends. And then there also is, evidence-based. One of the most evidence-based treatments is basically exercise. Evidence-based shows that exercise is effective for ADHD. And then there are over-the-counter treatments. So basically magnesium. Magnesium has been shown to increase dopamine. So that also is something. Omega-3 is actually helpful. And then also working with accountability partners in terms of just having support group. Sometimes a lot of times people don't realize, a lot of folks don't, say they know what to do. And so really that the whole issue is that ADHD is not, a lot of you've heard, I think it's Russell Berkeley, that it's really not a knowledge problem. It's a performance problem. And so really knowing that it's not, having all the knowledge isn't going to help you, but really it's the performance. And so really knowing yourself that it's really knowing where that barrier is. And so if you have that person, whether it's someone who's going to sit there and tell you that one area, if you have someone that, whether it's a friend or that usually doesn't work as well, but a coach you're paying for, who's really going to help you with that one area where you just somehow, for some reason, don't get past breaking down those work tasks, but you're paying $250 a week. It may not be enough to motivate you, but it may. And so I think it's really helpful to really utilize whatever you can to get there. And there's other, ADHD tax, it's always called. It's not a cheap disorder to have.
But then, of course, for women, all the hormone fluctuations and these hormonal waves start to come into play and affect how all of the treatments and all of the strategies and things that you set up. So how do these waves tend to affect these different medications, especially, but other lifestyle kinds of things? And then how can a woman talk to her healthcare provider if things are not working, if their medication isn't working as well during certain times of the month?
Yeah. So I think, number one, I think realizing that going into these conversations, number one, is sometimes just knowing that depending on who they're meeting with, if it's who and who's prescribing for them. So if it's a PCP, knowing that you may have limited time. If it is their psychiatrist, depending on how long they usually have with them. If it's someone who's, taking their insurance and it's usually a 5-minute appointment, it's going to be a little bit harder. So I think just setting themselves up for an appropriate expectation. So they're not going to feel so dissatisfied with what happens is number one. Also, maybe beforehand, possibly emailing to kind of set up, a better result. And maybe even breaking it up into 2 appointments or kind of setting up, some of the information or a pre-appointment type of email. But then also providing some information and kind of going in the appointment with the idea of providing as much information as possible, not to act as the expert, but knowing that this is somewhat new, that I don't think every physician is aware of it. It's not something I learned in medical school, so it's not something other physicians have. I'm really going in with the idea that I would focus more on the hormones and really just presenting it as almost, something as, doc, this is what I've noticed. I really noticed that during my cycle, I really noticed that during this time, I notice I'm really more forgetful or I'm more this. What do you think of? Do you think there's any correlation between this, and that? And could my meds be affected? And someone may just dismiss it. And at that point, you can just broach the idea of, is there a chance that these meds are less effective? Have you read anything about it? And just say it that way. You may not get anywhere, but at that point, I think that there's no harm in advocating. There's nothing wrong with that. And
but also going in with data. I mean, can you talk about the value of tracking ADHD symptoms alongside one's cycle, whether you do it on a paper calendar or some kind of electronic thing? Are there apps that you
can
recommend?
Yes.
I know some women have privacy concerns about these apps.
Yes. I mean, there's Clue, there's Flow, there's many apps. I think whatever you use, as long as you're consistent. I endorse all of them as long as you use them. And so that's the thing, really using them and being consistent with them. I also think sometimes even just, finding a great article and emailing your doc and just sending them, sometimes they're better with just reading something that's somewhat some jargon that has some medical stuff in it, that not that you have to feed their ego, but just to give them some information in case they haven't heard about it. But yes, also tracking for your own sake to say, hey, this is legit. I'm really noticing this. And then, going in there. And if you don't get the answers you need, it's not that you have to move on to someone else, but I would just keep advocating. The more you push, the more they're willing to take you seriously, that you're not just drug seeking. I think also being mindful of the fact that people usually push back when they're scared, when they're anxious, and that the medications that you're asking for, unfortunately, they're controlled substances, usually that they come with their own risks. And so sometimes they're getting policed because there's a little bit more of eyes on them. And so it's just a little bit more of a nuisance in terms of the prescribing rules. But I think that the more you advocate, the easier it is to get what you need and what's effective.
And now a word from our sponsor. At Otsuka, we believe that the human mind is infinitely valuable, including those navigating ADHD. That's why we're working to transform the way neurodevelopmental conditions like ADHD are understood and treated, making care early, equitable, and accessible through products, programs, policies, and advocacy. Otsuka people will defy any limitation that stands in their way until every mind is valued. Learn more at otsukaus.com/CNS. If you notice, if you're really taking notice of your ADHD symptoms throughout the month, as well as the symptoms of your hormonal fluctuations, recognizing these patterns by tracking that kind of data, getting that kind of information, can't that help you to work with your hormones instead of against them?
Oh, 100%. And then you can plan your weeks and your months better. If you have that type of job or that type of environment, like meaning that you won't schedule a podcast the week when you are in your luteal phase, or you won't schedule a trip when you're about to, go into that phase, or you can ask for more help from your spouse, or things that, or you really prepare and, you get headaches or cramps and things like that, and you just really track more. I think it gets a little bit harder when you're in that perimenopause and you can't track as much, or if you're on like an IUD, a lot of females another myth is that you can't track when you're on an IUD or birth control. Just because you're not menstruating doesn't mean you can't track. There's other ways to track. Just because you're not menstruating, you still have other symptoms. You still there's temperature changes. You still can have changes in just discharge. You still will have, there are other ways you can still feel differences. You can still feel cramping. You still can have, ovulation even when you have the IUD. That's not the only way, basically. That's not the only way that IUD, not having ovulation, is not the only way that prevents contraception. So basically, there are ways to track and make sure that you're keeping track of the different cycles, the different parts of your cycle.
And for some people, of course, for some women, the symptoms and the whole experience becomes a lot more serious. For some, it's milder. So can you please talk about PMD and PMDD and how prevalent are these and what sort of treatment options there are for someone who has co-occurring ADHD and PMDD, for example?
Yeah. So, I mean, it's so interesting because, so back before, PMS is something that I think most people really, when you hear PMS, it's just so common. Everyone's, thinks of PMS as just they've experienced it. They've at least had some physical symptoms of PMS. PMS is really just, you can have basically physical symptoms of breast tenderness. You can have bloated. You can feel like you're bloated. You can have, what else? You can feel a little swollen. You can feel a lot of like hunger. You can feel like you have more physical like symptoms of headache, migraines. And this all happens either like 2 weeks before your period, usually more like 10 to 7 days. What else? You can, then people also get like really moody. You can feel irritable. You can feel, and then also, so a lot of times your ADHD symptoms, if you have, this is all just still PMS. You can also, if you have ADHD, just feel like maybe your medicines are a little bit less effective, but nothing like that bad. And then for women with PMDD, which is basically what I call PMS on steroids. And so PMS is, I would say, 15 to 20%. It's high. But PMDD is it's PMS on steroids, and that's premenstrual dysphoric disorder. And that is, I think the percentage is like 5 to 8%. And it's basically when the estrogen and progesterone is inconsistent. And really, that is PMS on steroids. And it is much more severe. It really affects a woman's functioning. It really can prevent a woman from functioning during that time period in the month. And it really can happen once a month. It can make them not able to get to work, to take care of their family. It can hinder their life. It actually can be so severe that it turns into a, dysphoria where they become depressed. I've had women become suicidal. It is a cyclical mood disorder, meaning cyclical in the sense where it happens once a month. It can be very severe. Unfortunately, it really hasn't been well studied, just like many other disorders in females. And unfortunately, it hasn't been well acknowledged and well treated. So it's really a shame. I would say that the best, the evidence for the evidence based treatment is really number one, first identifying it. Number two, figuring out really, so it comes down to first diagnosing it correctly. And that is it really premenstrual dysphoric disorder? And so in order to tell it's premenstrual dysphoric disorder is number one, to know, are we sure it's nothing else? So are we sure it's not an exacerbation of someone's major depression? Or is it an exacerbation of someone's bipolar disorder type 2? Is it an exacerbation of something else psychiatrically? That's first. If it is that, let's just say someone has bipolar type 2, should we then increase someone's Lamictal instead of considering it just premenstrual dysphoric disorder, which happens all the time? And then if that's the case, that's what I do. If this is just happening during that time, they've never ever had any other times where they've had any depression, that happens a lot as well. Then I consider just treatment for the premenstrual dysphoric disorder. At that time, I can start something called luteal dosing of SSRIs, which is, I find really cool and interesting, which is basically giving them a pulse dosing of something like Prozac. So all that means is that they can take a drug like Prozac or Zoloft just during this period before, 10 days, 2 weeks before their period. And the reason is because they can use that medication to basically not act like an antidepressant the way we use them for other times like depression, but they can take it to take the place of progesterone. And the reason is what it does. It basically, you take it and it works it works basically like the way progesterone would. Because what is happening is when you have premenstrual dysphoric disorder, your hormones, your progesterone and estrogen are really fluctuating too much. And so what's going on is you're not getting enough of that progesterone at the right time. So the reason we need that progesterone, even though it's making us crampy and it's making us not feel good, like we're getting all bloated or we don't like it, we're getting hungry, we need it because at the end, the metabolite, when we're done with it, that's what gives us the calm feeling. So when we're done with that, we actually excrete it. We actually get that calm feeling at the end. And so the metabolite of it makes us calm and relaxed. And so what that Prozac does immediately is it actually gives them the calm feeling. So that's what I find cool about it. The Prozac that we give these patients immediately works like that progesterone metabolite. And so they don't have to take it for the full month. All they have to do is take it for 5 to 10 days. And so it's really cool. That's why it's called luteal dosing. They can take it just during that time period. And I'm not quizzing everyone on this. It's just a cool science fact. And so that's why I always tell people you're not going to get side effects. If you ever, you don't have to worry about any, people hear about SSRIs like sexual side effects or weight gain. Not that everyone's going to have those, by the way, anyways, but this is really cool because you bypass all of those. You're just taking it and it's just going to work like progesterone metabolite, and it's just going to work, and you can stop it right after you start your period.
And so it certainly offers hope to those who are experiencing some of the worst challenges with this.
100%.
I'd like to return to perimenopause.
Sure.
For a few minutes.
Sure.
The hormone swings we've already mentioned can feel so unpredictable. So what medication adjustments or nutrition or stress management tend to make the biggest difference during that particular time of a woman's life?
Okay. So during that time of their life, I think number one is knowing it's happening, because it can happen anywhere between early 30s and late 40s, and early 50s to mid 50s. And also basically is knowing it's happening and then being aware of any symptoms and knowing when your mother went through it or your siblings, sisters, 'cause that's one of the biggest predictors. And then also being aware of your family history of any cancer, hormonal cancer dependent, like any cancers that are hormonally dependent, so you can really know what your risk factors are in terms of treatment, since a lot of things have changed since back in the day with the Women's Health Initiative, and because the most important time for treatment for perimenopause is that for hormone replacement is actually during perimenopause. And so I bring that up because there are times where treatment may be important. And so, but for nutrition, I think that really implementing, and that also comes down to if you have this real high risk factor for breast cancer and endometrial cancer, ovarian cancer, you don't really want to be overdoing it with phytoestrogen and all of that stuff. But if you don't, that's a time to really think about adding in things like phytoestrogen and other types of sources that are natural ways to get some forms of, estrogen in you that are natural. But also thinking about, I would say, like B6, that is, a natural way. Other just B complex over the counter. What else? Definitely weight-bearing exercises. That's so, so important. People don't realize when your estrogen goes down, you're going to be at risk for osteoporosis. And that is the most important time. Before that happens, you want to make sure that you do all you can to basically increase your muscle mass, increase that calcium intake, everything you can. So, after basically postmenopausal, that is when you're increased risk for osteopenia, osteoporosis, basically bone loss, and sorry, I said muscle mass, bone loss, and also cardiovascular risk. So that is when women actually increase their risk, like men, of, heart attacks, strokes, all of that. Mm-hmm. And so estrogen is our friend when it comes to heart protection. And so it's really important to be mindful of that. So at that point, I think it's also important to be mindful of how we eat in terms of protecting us then. But also in terms of perimenopause and ADHD, I think also being mindful of hydration. Anytime we're going through perimenopause and like ADHD, you're going to notice like hot flashes. You're going to really just be noticing your medication that probably wasn't, making you as stimulated and is like off as before, maybe is making you like more jittery in your coffee. And if you're feeling like your heart rate's higher, if you're not as hydrated, it's going to be much more likely to make you hot and like it's going to feel off. So if you're only drinking like 20 ounces and you start drinking 40, you're not going to feel like that anymore. So
important. Yeah. So important. And so many women in perimenopause experience sleep problems and you mentioned jitters, heightened anxiety, sometimes even panic attacks and heart palpitations, as you just mentioned, and caffeine intolerance. And stimulant medication can also heighten all of those symptoms. But are there specific medications that are used to treat ADHD that can help with the symptoms but not exacerbate these kind of perimenopausal symptoms?
Yes. And also real quickly for sleep, I just wanted to mention that in terms of sleep, ADHD actually is a sleep-wake dysfunction. So it's a circadian rhythm dysfunction. And so I think that point, especially during the perimenopausal time period, it's so important to have the appropriate sleep. And so really any time when we're having that transitional point, but really during perimenopause is making sure you're getting up and waking up at the same time. I don't even mean just going to sleep and having adequate amount of sleep, but even on the weekends when maybe you don't have work, still setting your time, still setting your alarm to get up the same time. And also having appropriate amount of light in the morning, but also having appropriate amount of dark at night before you go to bed. And also making sure that people think of melatonin only for like feeling tired and going to sleep. But actually, there are studies that show that even a small amount, and I don't even mean like 1 milligram, but even like a 0.3 milligram that you can get over the counter and order can actually not just sedate. You don't necessarily need it to sedate you, but actually, if you're noticing your sleep is off, it actually can reset your sleep-wake cycle. So this isn't to actually cause sedation or for sleep, like insomnia. This is just to reset that disrupted sleep-wake cycle. But basically, so for medication or treatment for ADHD during that time period, I would say magnesium is number one. Really something like magnesium, like omega-3, magnesium, what else? Calcium, magnesium are my real go-tos. They really do help.
Mhm.
And exercise, but those really are top. I've had people who really do well when they start implementing, enough magnesium, enough calcium, and taking it the right way, the right time. People don't stick to the right amount and really give up very quickly.
Important to work with your prescriber, your practitioner on that to find those correct levels and that.
Yeah. And
Not just to wildly take them because you heard they work,
Exactly. And also just to be mindful that caffeine, sometimes people don't realize that they're having as much caffeine as they don't realize how much they have. Also, there's no reason that you have to always have, they can have decaf. It doesn't always have to be regular caf. You can, you don't realize how much is in certain types of coffee drinks and what time of the day, things like that.
Yes, now also with midlife, many women may experience memory lapses, mood swings, and worry about whether it's ADHD, perimenopause, or early dementia or Alzheimer's. So what do they need to know? What should they watch out for? Can you talk about how practitioners kind of look at this and maybe tease these symptoms apart to know what is really going on?
Yeah. So basically, with ADHD and with, differentiation between Alzheimer's and other forms of dementia, it's different. And so when we're looking at ADHD, we're really looking at things like executive functioning. Number one, we're looking at the ability to sustain attention. But with executive functioning, we're looking at things like the working memory, which is the ability to hold information long enough to complete other tasks. We're looking at the ability to regulate their time. We're looking at things like word finding, things like that. Yes, that can overlap with other forms of dementia. However, usually, with dementia, with Alzheimer's, it presents differently. With ADHD, if we really take a look and when I go through someone's history and I really sit there and this takes time, I'm really able to identify that some of this has been there, that we're really able to go back and really even back to when they were in their grade school, at least some point in maybe middle school. And, that they always struggled a little bit with maybe possibly not every symptom, but disorganization or maybe being a little chatty or interrupting or having like no filter at times or compensating by being perfectionistic or a little anxious. As they got older, maybe the word finding got a little bit more difficult, or they've always been poor with directions, things like that. So I always say that some of these issues with directions or being a little bit more scattered get a little worse. Also, someone with ADHD almost looks like they use it incorrectly, but almost some of the terms is they're so OCD. Well, they're not OCD. They compensated with list making. And by doing having all these strategies that work for them, they almost utilized executive skills that they taught themselves throughout the years, but they no longer are using them anymore. They're maybe retired. And so without, using those tools, maybe their brain is no longer in that high use, and also comes with some dulling cognitively. And there could be some mild cognitive impairment. Doesn't mean that there's necessarily, Alzheimer's in place. But both can be true. You can also have ADHD and mild cognitive impairment, really differentiating what's going on. And so really teasing that apart is really seeing a specialist, working with possibly a psychiatrist and also your GP, general practitioner, doing, some general testing, and also realizing that can change over time. I think really number one, getting on the right dose of stimulants. If you've never been treated for ADHD, I believe it's never too late to be treated. Also, if you're treated with stimulants, that doesn't prevent you from being treated preventatively with memory medications. You can be treated for both. You're completely treating different things. With ADHD, you're working on the dopaminergic system, so increasing the dopamine. With memory medicines, you're working on a different chemical, which I haven't mentioned, just to confuse everyone more, the acetylcholine. So most of them, there's other ones, and so that's one thing. Also with ADHD, the forgetfulness, the word finding, it presents differently. It's not as profound. However, there is one form, of dementia that I would say is a little more similar to ADHD, which people don't realize. And that's something called Lewy body dementia. And I only bring that up because in mild forms of Lewy body dementia, I always say that it can present like ADHD intensified. And when I say that, it's because a lot of times in this mild form, you can have issues with like spatial awareness and like directions and this executive dysfunction, but then you're back to normal. And so what happens is one day you're feeling, you notice you're really all over the place. You can feel really scattered. You can't turn on the remote. You can't do this. And then the next day you're completely normal. And so family members don't know what's going on. And you almost look like you have ADHD one day and the next day you don't. But if that happens and someone really didn't have any of those symptoms throughout their life, then you want to think what's going on. But if they always had a little of it, let's leave it at what it is.
And then if you know that all these hormonal changes are going on, they're in perimenopause, and that's another whole thing.
So that's completely different.
Where can women find providers who understand the interactions between hormones and ADHD, since a lot of providers may only be versed in one or neither? And what questions should they be asking when they're evaluating a provider?
Yeah. Unfortunately, I think a lot of people, what they tell me is that it's hard to be choosy because there's just no one, out there, and it's really hard. But I think really it's just coming down to someone who cares, someone who wants to be open and care. And so that's number one. But I think going online and finding someone who either specializes in women's health. So it can be someone who is specialized in women's health, whether it's a prescriber in psychiatry, in women's health, usually someone even in OB-GYN, someone, even a general practitioner, but their focus is women's health, integrative medicine, functional medicine. There is a lot of overlap now, which is nice. I do work sometimes in close, basically overlap with some other providers in the area where we will connect, someone will be prescribing this and we'll kind of connect in terms of, well, yeah, it sounds great. They're going through some menopausal treatment and kind of make sure that the ADHD meds are high enough, or even some fertility treatment. So I think just making sure that you're finding someone that's willing to be open to the possibility that they may not know that much, but they're willing to be open. I would say looking online on even, in your area, Psychology Today, I think still has providers that are, within your zip code. I think going online, there are different through CHAD, through Attitude, through other types of organizations. There are some organizations that focus on menopause as well as perimenopause, as well as women's mental health. And there's so many now. And I even just the other week, I was looking through, and there are a lot of different websites that really provide a lot of lists of names, and it's really neat. There's a lot of different support groups. There's a lot of different things that are out there, so much more than there was even 5 years ago. So I think really word of mouth is really important.
And that brings me to my final question for you for today, which is about research. Let's talk about the research on this topic. There isn't a lot. Do clinicians feel they have enough information to treat women with ADHD? If not, what research information would be helpful? And how would you characterize the need for further research? Are there any promising directions?
Yeah, I mean, not really. I would say we're decades behind, like decades. The momentum is building, but most ADHD trials historically have excluded women. Forget like the different hormones, but women in general have been excluded. The menstrual phase tracking has been excluded. There are some emerging studies now that are examining the role of estrogen and dopamine modulation and how hormonal contraception alters stimulant metabolism. I do know that there is some, what else have I known about? Promising direction of like the cycle-based dosing studies and like perimenopausal ADHD treatment protocols, anything that there could be like some, medication involvement. But we're still hungry for more data, clinicians, providers. What else? There's the most accurate insights are really observational data that are coming from women themselves. Most of it is anecdotal. Like I get all of my information from women, from them telling me, but the studies are coming. The more we push, the more they're willing to do the research. And there is stuff that's finally being done, but we don't have the data yet.
Well, thank you so very much. Now, before we close, is there anything that either I didn't ask you or that you would like to close with?
No, I just think that I guess I would say the one thing is that really, with having ADHD and also having these hormonal fluctuations, I think that, you're bound to miss things because you have ADHD. You're bound to miss things. So really keeping track as much as you can and writing things down so you don't miss that. And so you remember that happened, because you'd be surprised how much you forget. Especially, I can tell you as a prescriber of and a supposedly expert on ADHD and also PMDD, perimenopause, all of that. I even missed a lot of things in myself. Make sure you keep track and write it all down.
Thank you. Thank you so very much for your time today. Great conversation.
Yes, you're so welcome.
At Otsuka, we believe every mind is infinitely valuable. including those navigating ADHD. That's why we're working to transform how neurodevelopmental conditions are understood and treated. Discover more at otsukaus.com/CNS. This podcast has been brought to you by CHAD, Children and Adults with ADHD.